utmost, that is the field of endocrinology, physiology of endocrines. So let us enter into the world of endocrinology according to the FCPS Part 1 curriculum of various disciplines. As you will know, endocrine means the ductless glands because they pour their secretion into the general circulation, that is, into tiny capillaries. And there is some gender differences in the endocrines. For example, now testes are in the males and ovaries, corpus luteum and placenta are the endocrine organs in the female. Now, these endocrine cells are the ductless cells. They secrete a chemical secretion called as a hormone. So what is a hormone? A hormone is a chemical secretion. It is secreted from the ductless or endocrine tissues or cells. It is poured into the capillaries or to the general circulation and is circulated through the plasma. And it affects only those cells which have got high affinity specific receptor for that hormone. So then the question arises, what are the types of hormone? So there are various ways to classify hormone, but the most accepted is now classification according to the chemical structure of a hormone. Hormones could be peptides, so that is proteins. That is, they are made up of chains of amino acids in their structure. For example, hormones of the sum of the hormones of the anterior pituitary, hormones of posterior pituitary, hormones of endocrine pancreas, hormones of parathyroid gland. So they are peptide or protein hormones. And then hormones could be steroid hormones. So that is, they are derived from common precursor called as cholesterol. They are not true esters of fatty acids with alcohol. And these steroids have got common structural configuration, that is a ring, that is cyclopentano parhydrophenanthrin ring, C-triple-P ring in their structure, and they are derived from cholesterol. So steroid hormones are hormones of the adrenal cortex and hormones of the gonads, that is testes and ovaries. Vitamin D is also a vitamin as well as a hormone. So vitamin D3 is also a steroid hormone. So adrenocortical, testicular, ovarian, and vitamin D3 are steroid hormones. And then hormones could be amino acid derivatives. For example, thyroxine or T3, they are derived from a common precursor called as tyrosine. Please mind, tyrosine is a common precursor for secretion of T3, T4, adrenaline, and noradrenaline. And hormones chemically could be catecholamines. So that is, they've got catechol ring in their structure and amine or NH2 group as a side chain. For example, catecholamines are epinephrine and norepinephrine. Now the question arises, do all these hormones exert their action at molecular or cellular level by one mode of action? The answer is no. So they have got different mode of action. How do hormones act at the cellular level? Exactly, we don't know even of today, but there are various hypotheses, theories which are accepted. So that is the peptide hormones, hormones of the posterior pituitary and parathyroid, and some hormones of anterior pituitary. They circulate in the plasma. And please mind, hormones circulate in the plasma mainly, that is over 90% in bound form. Bound to what? Mainly bound to plasma protein. Which plasma protein? Especially to albumin and globulin, especially to globulin. So it is the globulin to which hormones are mainly over 90% attached, and they circulate in the plasma. It is around 5% of the hormone which circulates in the plasma in free form. And please mind that it is the free form of the hormone which is biologically active. And free form and the bound form, they are interchangeable. Free could be bound to globulin to make it bound form, and globulin could be detached and will render it into free form. So it is the free form of the hormone which will come to the outer surface of the cell membrane as shown in the slide. So here in the outer surface of the cell membrane for receptor protein for the peptide hormone is located. So hormone receptor complex is formed in the cell membrane. So that is the receptor for the peptide hormones are mainly located in the cell membrane. So they have got membranous receptors. Hormone receptor complex activates adenyl cyclase. So it activates, adenyl cyclase is also present, already present, but it activates adenyl cyclase. So this activated adenyl cyclase and this translocated into the cytoplasm. It goes to the ATP, that is to the mitochondria, and converts adenosine triphosphate into 3' 5' AMP, which is cyclic in structure called as cyclic AMP. So that means peptide hormone acts at the cellular level by mediation of cyclic AMP. Overdoing of cyclic AMP is checked by another enzyme present in the cytosol called as phosphodiesterase. So this phosphodiesterase breaks down the cyclic structure of cyclic AMP and biological activity of the molecule is lost. And then the cyclic AMP affects on the cellular membrane. It could lead to contraction of the muscle fiber, relaxation of the fiber.
Sorry to interrupt. आपकी slide stuck हो गई है. Message भी आ रहा है, slide stuck.
Right, slide तो मैं उसी पे चल रहा हूँ.
It's okay now.
Oh yes.
ठीक है, okay, thank you sir.
Right, and cellular effect. So this peptide hormone acts as a first messenger, whereas cyclic AMP acts as a second messenger for hormonal action. So what does it do? It either causes contraction of the fiber or relaxation of the fiber, or it opens up the gate for transport of ions or other substances into the cells, or even it may form another protein or another enzyme which may act as a third hormonal messenger. So the summary is that is the peptide hormones have got membranous receptor and they act at the cellular level through cyclic AMP system. Now look at this slide, like it is not only the type of the hormones on which the response depend, it could be the different variety of the receptors as well. For example, if epinephrine and norepinephrine affect on beta receptors to increase metabolic rate or to lead to hyperglycemia, so this effect is mediated through cyclic AMP system. But when these catecholamines affect on the alpha receptors to lead to vasoconstriction of the blood vessels, especially the arterioles, so this effect is not mediated through cyclic AMP system. So then apart from the chemical nature of the hormone, right, it is the receptor. Look at the vasopressin. When vasopressin, which is ADH, vasopressin causes antidiuretic effect on the distal convoluted tubule, and the distal collecting duct and collecting tubule. So this effect is mediated through V2 type of receptors, and this is through cyclic AMP system. But when vasopressin affects through V1 type of receptors to lead to constriction of the blood vessels, so this effect is not mediated through cyclic AMP system. So how do hormonal effects differ from each other? So that is, one is on the chemical structure of the hormone, second is on the type of receptor upon which it is going to act upon. And thirdly, it is the immunohistochemistry or immunocytochemistry of the target cell. For example, if catecholamines affect on the liver and muscle cells, they lead to glycogenolysis, that is breakdown of glycogen into glucose. But when catecholamines affect on the adipose tissue, they won't bring about glycogenolysis. So they will lead to lipolytic activity. When these catecholamines will affect on the heart, so they will lead to positive inotropic effect, which means increase in force of contraction of the heart. or they may lead to positive chronotropic effect, which means increase in rate of the heart. So it is on the type of the chemical structure, it is on the type of the receptor, it is on variety of the immunocytochemistry of the target cell that hormonal response differ from one another. And then there are certain glands which also secretes neurotransmitters, like hormones as well as neurotransmitters, especially the gut cells. So gut hormones, like many of the gut hormones, when they're secreted from GIT, endocrine cells, they are called as a hormone. And when these substances or the hormones, they are secreted from the brain cells, so they will be called as neurotransmitter. And those substances, are those substances which are hormones as well as neurotransmitters, include substance P, ACTH, MSH, beta endorphins, enkephalins, somatostatins, cholecystokinin, even insulin, even secretin, gastrin are vasoactive intestinal peptide. So when they are secreted from the brain cell, they are called as a neurohormone. Now here another term comes, which is a neuroendocrine gland. Now neuroendocrine glands are those glands which embryologically take their origin from the neural portion, but have been modified to secrete a hormone. Which are the neuroendocrine glands? They are the pineal glands, hypothalamus, adrenal medulla, posterior pituitary gland. So pineal gland, hypothalamus, adrenal medulla, and posterior pituitary gland are called as neuroendocrine glands or tissues. And their secretion is called as neurohormones or neurosecretion. Now, how do steroid hormones exert their action at the target cell? Like at the target cell. Steroid hormones, as I did tell you, are adrenocortical hormones, hormones of the ovaries, hormones of the testes, and vitamin D3. So steroid-free form of the steroid hormone is internalized into the cytoplasm of the target cell, where protein receptor is present. So steroid hormone protein receptor is made up in the cytosol. So this gives us one lesson, that is, the receptor for steroid hormones are located in the cytoplasm of the target cell. Receptor for protein hormones are located in the cell membrane of the target cell. So this active complex in the cytosol is translocated into the nucleus of the target cell, is goes to the chromatin. On chromatin, messenger RNA, it goes to the chromatin, where DNA is stored in the form of triplet genetic codons. And this converts messenger RNA into transfer RNA into ribosomal RNA. Now, this conversion of DNA to messenger RNA, ribosomal RNA, and transfer RNA in the nucleus of the target cell is called as nuclear transcription. So it stimulates nuclear transcription. So this messenger RNA, enjoying its ride on the transfer RNA, is translocated from the nucleus back to the cytoplasm, and it goes to the rough endoplasmic reticulum. On the rough endoplasmic reticulum, clusters of ribosomes are present, called as polyribosomes. So it affects on the ribosomes located on the rough endoplasmic reticulum. On the ribosomes, the number of amino acids, right? The nature of amino acids, the sequence of amino acids, and the pattern of amino acids is laid down. So that means it leads, this is called as ribosomal translation. So that means steroid hormone, they have got cytosolic receptors, they stimulate nuclear transcription and ribosomal translation and synthesizing a new protein or a new enzyme. So this new protein or new enzyme then acts as a second messenger for hormonal action. So that means steroid hormone acts as a first, whereas newly synthesized protein or enzyme act as a second messenger for hormonal action. So this newly synthesized protein or enzyme exerts its physiological responses on the cell membrane, which could be contraction of the muscle fiber, relaxation of the muscle fiber, or opening the gate for other ions or substances, or even synthesizing a new protein or new enzyme to act as a third messenger for hormonal action. So that means steroid hormones act through synthesizing new protein and new enzymes. Now look at the thyroxine, T4, tetraiodothyronine, and triiodothyronine. So they have got membranous receptors. They don't have membranous receptors. They don't have cytoplasmic receptors, but they have got nuclear receptors. So that means thyroxine is directly internalized into the nucleus of the target cell, where receptor is present. It makes a hormone receptor complex, and that goes back to the cytoplasm on the ribosomes, and then there is synthesis of new protein and enzymes like to exert its physiological responses. Now, then, there are many intracellular hormonal messenger which have been identified so far. So first of all, is cyclic AMP, which we have just discussed, and then is newly synthesized protein or enzymes by the steroid hormones. And then the third hormonal messenger is gamma aminobutyric acid, and then is protein kinase C, and then is phosphatidyl inositol system, PI, phosphatidyl inositol system. And then are the G proteins, even LHRH, may act as an intracellular hormonal messenger. And calcium, for that comedulin is a protein, calcium comedulin complex. And then is polyamines, especially putrescine, so they may act as intracellular hormonal messenger. But how do hormones affect on the target tissue? Even it is still unknown. Like, let us see, right, about regulation of the hormonal secretion. What do we mean by the word regulation? Regulation means control of hormonal secretion. If you look at the level of hormones in the plasma, they are very narrowly defined physiological range. For example, 0.08 nanogram per liter or deciliter per deciliter up to 1.5 like nanogram per deciliter. So it is how this narrow defined physiological range is maintained is called as regulation. So regulation of hormonal secretion is done by the neuroendocrine system, by the nervous system, and by the endocrine system. And by the endocrine system, by the feedback way. And feedback system, you all know, are of two types, positive feedback system and negative feedback system. So let us talk about positive feedback system first. So positive feedback system is when the response accelerates the stimulus, like when the response accelerates the stimulus, it is called as a positive feedback system. Like now in physiology, there are very few examples of positive feedback system when sudden, spontaneous, and explosive physiological response is required, positive feedback system sets in. And those examples in endocrinology are mainly met with the female reproductive system. For example, mid-cycle LH surge, mid-cycle ovulation, and then is parturition oxytocin reflex, then suckling prolactin reflex, suckling oxytocin reflex, or milk ejection reflex. So they are positive example of positive feedback system in physiology. Otherwise, positive feedback system in pathology is usually a pathology that is when compensatory responses or negative feedback system fails, positive feedback system sets in, a vicious cycle is produced which leads to the disease process. But this mid-cycle LH surge, mid-cycle ovulation, parturition oxytocin reflex, now suckling prolactin, suckling oxytocin or milk letdown reflex, they are example of positive feedback system of reproductive system or endocrinology in the domain of physiology. And mainly overwhelmingly, hormonal control is regulated by the negative feedback system. When the response decelerates, when the response inhibits the stimulus, it is said to be negatively fed back. And negative feedback system may act at hormone loop. What is hormone loop? Look at the regulation of hormones at hypothalamo-pituitary-thyroidal axis. So that is TRH is secreted from hypothalamic neuronal cells, stimulating TSH secretion from anterior pituitary cells, which stimulates thyroid cells to produce T4. If T4 rises in the plasma by negative feedback system, it inhibits TSH secretion from anterior pituitary or TRH secretion from the hypothalamus to bring back thyroxine back to normal. So that means, so this example fits in well in hormone loop of negative feedback system. Similarly, hormones of hypothalamo, pituitary, adrenal axis, adrenal cortex, are also hormone. So hypothalamo, pituitary, gonadal axis, that is hormones, pituitary, testicular, or hormones, pituitary, ovarian axis. So these hormones also are regulated at hormone loop of the negative feedback system. But then is substrate hormone loop of the negative feedback system. What is it? Look at growth hormone. Growth hormone causes rise of blood glucose, like blood glucose, serum plasma glucose. Now, this rise of plasma glucose inhibits growth hormone secretion from the anterior pituitary cells. So this blood glucose or glucose is not a hormone, it is a substrate. So this negative feedback system is between substrate hormone loop of negative feedback system. And then it could be mineral hormone loop of negative feedback system. For example, look at PTH, parathyroid hormone. So PTH is secreted from parathyroid cells, and it increases plasma calcium level. Rise of plasma calcium level will inhibit.
Slide stuck हैं, sorry for interruption, लेकिन आपकी slide stuck हैं. Slides में से regulation of hormone secretion show हो रही है.
Is it okay now?
No, sir.
Is it okay?
No, sir.
Is it okay now?
नहीं सर, अभी भी regulation of hormone secretion ही show हो रही है.
ये स्लाइड पूरी शो हो रही है?
Yes sir, अब show हो रही है.
ठीक है सर.
अब शो हो रही है?
Yes sir.
Yeah, okay, thank you. Now, then is mineral hormone loop of negative feedback system. So that is PTH will stimulate serum calcium level in the plasma. Rise of calcium would inhibit secretion of PTH. So this is mineral hormone loop of negative feedback system. So that was endocrinal control of hormonal secretion. Now let us talk about neural control of hormonal secretion. So there are various nerve fibers arising from various parts of the brain, like adrenergic nerve fibers secreting norepinephrine, cholinergic nerve fibers secreting acetylcholine, dopaminergic nerve fibers secreting dopamine, serotonergic nerve fibers secreting serotonin, endorphinergic nerve fibers secreting endorphins, encephalinergic nerve fibers secreting enkephalin, GABAergic nerve fibers secreting GABA. So all these neurotransmitters have either excitatory or inhibitory or both on various tissues effect of hormonal control. And then there are certain mechanisms which don't fit in well into neuroendocrine system. So we have gathered them under the heading of chronotropic control. For example, diurnal rhythm. There are some hormones which vary in their secretion from day to night. So that means they depend on the light and dark cycles. So suprachiasmatic nucleus of the hypothalamus and the pineal gland, they are sensitive to light and dark cycle. And these light and dark cycle are more pronounced in the lower animals as compared to the mammals or in human being. And then a sleep wakefulness cycle. So there are certain hormones which are more during sleep, and there are others which are more during wakefulness. For example, the sleep wakefulness cycle is followed by hormones of hypothalamo pituitary cortical axis. So that is CRH, corticotropin-releasing hormone, adrenocorticotropic hormone, and cortisol, they follow the sleep wakefulness cycle. and prolactin during the lactating age, lactating mothers, and growth hormone during the growing age only. So growth hormone during the growing age, prolactin during the lactation phase, and hormones of hypothalamus, pituitary, cortical axis, CRH, ACTH, and cortisol, they follow the pattern of sleep wakefulness cycle. And then there is change in the rate of secretion of hormone in 24 hours. That is called as circadian rhythm. Hormones of the hypothalamus, pituitary, cortical axis. So cortisol, like at 3 to 4 hours before wakefulness, like before wakefulness is at the peak. And then after the day's tiredness, when we go to the bed, now this cortisol level is at the lower level of the normal range. So that is why the clinicians always advise that this cortisol concentration should be measured at 9 a.m. or 10 a.m. or 8 a.m. sharp, that is and the next subsequent samples must be taken at the same time. And then there is a circadian rhythm, which means change in the rate of secretion of the hormones on hour to hour basis. हर घंटे डेढ़ घंटे के बाद circadian rhythm. For example, hormones of endocrine pancreas, insulin and glucagon. So rate of insulin and glucagon that keeps on changing depending on the plasma glucose level in between the meals, immediately after the meals, now in between the meals, just before the meal, and then during the meal. So that is, they follow the pattern of circadian rhythm. And then there is an ultradian rhythm, change in rate of secretion of the hormone on moment-to-moment basis. For example, adrenaline. Adrenaline is secreted, it goes away very quickly, fades away, and then when another thought of stress comes in the mind, it may shoot up again. So this is called as ultradian rhythm. And then there is menstrual rhythm. Hormones of hypothalamus, pituitary, ovarian axis follow a repetitive rhythm in the rate of secretion of hormones in a monthly repetitive fashion, and we will have now, and that is called as a menstrual rhythm. And seasonal rhythm. Seasonal rhythm is not that pronounced in the human beings, but various seasons, for example, in the spring weather, in the autumn, in very cold and very hot weather, like the hormonal secretion keeps on changing, and then the hormonal secretion and various stages of development, which we will talk about in a while, now are changing. So that means hormonal secretion is controlled within the defined physiological range by negative and positive feedback system, by the neurotransmitters through the neural system, and by certain diurnal, circadian, menstrual in the females during the reproductive age fashion to keep it within the normal physiological range. So this is the last slide of general physiology, then general endocrinology, and then we will shift on to systemic endocrinology. So this is hormone-related cancers, or you might have heard the term ectopic secretion of the hormones, which means secretion of hormones from the tissues other than normal. For example, like ACTH hormone is physiologically secreted from the anterior pituitary gland, but oat cell lung carcinoma, bronchial adenoma, thymus tumors, pancreatic islet tumors, medullary thyroid carcinoma may ectopically secrete ACTH, and the patient may show cushingoid features. For example, PTH is physiologically a hormone of the parathyroid gland, but squamous cell lung carcinoma, renal carcinoma, pancreatic tumors, ovarian tumors, and many squamous cell carcinomas may ectopically secrete PTH and leading to hypercalcinosis. For example, ADH is hormone of the hypothalamus mainly, but oat cell lung carcinoma may ectopically secrete ADH and may lead to rise in the blood pressure. For example, human chorionic gonadotrophin, HCG, is hormone of the placenta physiologically, but large cell lung carcinoma and hepatic carcinoma may ectopically secrete HCG, giving the false positive pregnancy test. And look at human growth hormone. Now, normally it is secreted from the anterior pituitary cells, but adenocarcinoma of the lung, gastric tumors may ectopically secrete growth hormone. Erythropoietin is hormone of the kidney, but hemangioma, that is of the cerebellum, pheochromocytoma, tumor of the adrenal medulla, hypertoma may ectopically secrete erythropoietin, leading to polycythemia or erythrocytosis. Renin, another hormone of the kidney physiologically, but may ectopically be secreted from oat cell lung carcinoma, leading to reninism, leading to rise of blood pressure. So, and then there is a level of the endocrine defect. Now, sometimes your MCQs or questions may be termed as primary deficiency or secondary deficiency or tertiary deficiency of the hormone. What do we mean by it? Like, so if I give you a clinical example, if a patient reports to your endocrine clinic, right, he has got fall in T4, less T4 than normal in the plasma, rise of TSH, and normal or increased or variable TRH, hormone of the hypothalamus, which is thyrotropin-releasing hormone. What will be your provisional diagnosis? If T4 is less than normal, TSH above normal, TRH is variable, what will be your provisional diagnosis? So provisional diagnosis BP, this is T4 is low, probably because of the thyroid atrophy changes. Like TSH rise is due to, there is nothing wrong with the pituitary, fall in T4 through negative feedback system has stimulated pituitary to cause rise of TSH. So this particular defect is a case of primary hypothyroidism. So target organ failure, in this example, thyroid failure is a case of primary hypothyroidism. So if another patient reports to your clinic, he has got a different blood picture, like his T4 is below normal and TSH in the plasma is below normal, but TSH is raised. So what will be your provisional diagnosis? So this rise of T4 is probably due to rise of TSH coming from the pituitary because of the pituitary tumor or because of the ectopic TSH secretion. So this is a case of secondary hypothyroidism. If the defect of the endocrine is at pituitary level, in this case, like it is a case of secondary endocrine defect. In this example, it is a case of secondary hypothyroidism. And a third patient reports to your endocrine clinic. He has got fall of T4 below normal, TSH is below normal, and TRH is below normal too. So what is the provisional diagnosis? So this TSH, fall in T4 is because of fall in TSH, and fall in TSH is because of fall in TRH. So this is provisionally a case of hypothalamic failure, or he is a case of tertiary hypothyroidism. So the summary is, if there is a target organ failure, it is a primary endocrine defect. If it is a pituitary deficiency or failure, it is a secondary endocrine defect. If it is a hypothalamic failure, it is a tertiary endocrine defect. Now then, this is a crowded slide. I will pick up the important points for you. I understand you will not be able to see it. Now, as we consider drug interaction for therapy of the patients, similarly, drug-hormone interaction has to be taken into account while prescribing an endocrine patient. For example, contraceptives, like whether injectable or oral, estrogen component of the contraceptives. That causes rise of T4 and rise of cortisol in the plasma. So that means if any female reports to your clinic, she has got features of hyperthyroidism, she has got features of Cushingoid features, rise of blood pressure. So ask her a question if she is on pills or injectable contraceptives. If she is on, then ask her to refrain from 4 to 6 weeks and come back for the hormonal estimation. Look at thiazide group of drug, diuretic, very widely used. Prolonged use of thiazide causes fall in insulin secretion or diabetogenic features. if patient reports to your clinic, now if he shows like diabetogenic features, and if he's on thiazide group of drugs, change the thiazide group of drugs to some other group of diuretics. Now, Dilatin is a drug which is widely given by the psychiatrist. Now, this Dilatin causes fall in T4 and fall in insulin. So patient will come with hypothyroidism and with diabetogenic features, which is contradictory. Hypothyroidism is characterized with hypoglycemia, but here hypothyroidism will be associated with hyperglycemia. So if this patient is Dilatin group of drug, now request the psychiatrist to change the group of drug. Look at tranquilizer. Thorazine group of tranquilizer causes rise of prolactin level in the plasma. It causes hyperprolactinemia. So secondary infertility brought about by the overuse or prolonged use by the thorazine tranquilizers will lead to hyperprolactinemia. So this tranquilizer in those cases may be changed to some other group. So that would mean there is some drug hormonal interaction, which is to be taken into account while putting the patient on hormonal therapy. Now, up till now, during this half an hour, we have been talking of the general principles of endocrinology, like from where 10 to 15% questions in your MCQs are set from the general principles in paper 1. And now, if there's a question, say for example, how is cortisol like circulated in the plasma mainly? Now you will take globulin. Where is hormone thyroxine or any other hormone inactivated mainly? That is in the liver. Like, so this is in which form of the hormone is circulated in the plasma? Bound to albumin, bound to globulin, free form, bound to pre-albumin. So you will take globulin. So about 10 to 15% of the questions are set from endocrinology, are set from the general principles which we have talked in half an hour only. Like, so say for example, if the question is the peptide hormone receptor or parathyroid hormone receptors are mainly located in mitochondria, cytoplasm, cell membrane, in the nucleus. So you will take the cell membrane. Like, so about 10 to 15% of the questions from endocrinology, they're set from the general principles which we have talked about in half an hour. Now I'm switching on to systemic endocrinology. Like in systemic endocrinology, we will start from hypothalamus as a neuroendocrine organ, then we will go down into the anterior pituitary gland and then to posterior pituitary gland, and then we will come down to thyroid gland, and then we will switch on to the posterior surface of the thyroid gland. We will talk about parathyroid hormone, and then we will talk about like endocrine pancreas, and then we will go to adrenal medulla and adrenal cortex, right? So let us talk about systemic endocrinology, and let us talk about hypothalamus. I'm not going to talk details of the functions of hypothalamus. I'm only concerned with hypothalamus as a neuroendocrine organ. Look at this physioanatomical slide. Structure from this slide shows structure function relationship of hypothalamus. Right? As you know, as you can see from this slide, hypothalamus is connected with various parts of the brain by various nerve fibers secreting neurotransmitters at their nerve ending. For example, look at the prefrontal cortex. Prefrontal cortex, as you all know, now it carries the awareness of oneself. When it gets ablated, so one is not aware of the surrounding, and one is not aware of the self. So it's fibers, like neural fibers, neurals from the neural cell, neural fiber arises, and they terminate at medial hypothalamus. Look at the amygdala and the olfactory tubercle on the left column of the slide, like which is the part of the limbic cortex or associated limbic lobe. So they carry the sensations of fear, rage, emotional, social, and sexual behavior. So their fibers terminate at medial hypothalamus. Look at the middle column of the slide, visual area, proprioceptive area, and taste area. Their fibers, after laying in the hippocampus, they terminate at anterior hypothalamus. Somesthetic area from the synesthesia area, after terminating, making relay in thalamus, they terminate at anterior hypothalamus. And olfactory cortex, now it perceives the sensation of olfaction, like a smell, so they terminate at lateral hypothalamus, and by ascending and descending fibers, they go to the brainstem. So that would mean all these nerve fibers, they secrete various excitatory and inhibitory neurotransmitters, like acetylcholine, like dopamine, like serotonin, like bombacin, like substance P, like enkephalins, like GABA, like so many neurotransmitters are released, and these neurotransmitters may stimulate or inhibit secretion of hypothalamus hormones called as neurosecretion of neurohormone. And then the question arises, which are the hormones of hypothalamus? Hormones of hypothalamus are ADH and oxytocin. ADH is secreted from supraoptic nucleus of hypothalamus. Like oxytocin is secreted from PVN, paraventricular nucleus of hypothalamus. Apart from ADH and oxytocin, hypothalamus secretes various releasing hormone and inhibiting hormone, like various releasing and inhibiting hormone. Releasing hormone, they stimulate, and inhibiting hormone, they inhibit secretion of the hormones from various endocrine cells. So this slide also shows the applied physiology. What is the potential clinical use of these hypothalamic hormones? For example, growth hormone releasing hormone is used in the treatment of the short stature, like short stature. And growth hormone inhibiting hormone is used in the treatment of some cases of acromegaly. Now, prolactin is controlled only by one hormone, which is one of the forms of somatostatins. So that is growth prolactin inhibiting hormone, which is used in selective cases to treat the galactorrhea or the breast cancers. So LH, FSH, like luteinizing hormone and follicle stimulating hormone, they are regulated by LHRH or GnRH. So to this GnRH or LHRH, so they may induce fertility or they may control fertility. Now, it depends on the dose of the hormone, on the route of administration of the hormone, in the pattern in which they are given, and on the day of the menstrual cycle on which they are given. If LHRH or GnRH is given in large amounts by continuous infusion without taking into account of the day of the menstrual cycle, it will cause down-regulation of its own receptors on the pituitary cells. So this will cause down-regulation of its own receptors and would inhibit fertility or control fertility. But when LHRH or GnRH is given in volleys or pulses in very small doses subcutaneously at 10th, 11th, and 12th day of a menstrual cycle, so then here it may stimulate its own receptors on the pituitary cells, and here they will stimulate the fertility. And look at ACTH. Now, ACTH is controlled by corticotropin releasing hormone. Its competitive analog is used in the treatment of Cushing disease. Look at TSH. TSH is controlled by TSH-RH or TRH, and it is used in the treatment of hypothalamic hypothyroidism. And hypothalamic hypothyroidism, we have known the principle from the general principles of endocrinology, is a tertiary hypothyroidism. Tertiary is a form of tertiary hypothyroidism. Then we move on to anterior pituitary gland. Pituitary gland in higher mammals, as in human beings, is divided into two, anterior pituitary and posterior pituitary. Now, in intermediate lobe or median part of the pituitary is rudimentary and non-developed in human beings. In lower animals, as in amphibians and lower animals, now this middle lobe is very much developed, and that secrete MSH, melanocyte stimulating hormone. And this MSH in the lower animals is responsible for pigmentation activity. In human being, ACTH hormone in structure, it resembles with molecule of MSH. So melanocytic activity in human being is mainly brought about by ACTH because of its structural resemblance. Now, anterior pituitary is a pure endocrine gland because if you look at the upper column of this slide, because it originates from a glandular tissue, from the roof of the mouth, embryologically in the form of Rethke's pouch. So anterior pituitary gland developmentally or embryologically develops from a glandular cells or tissues from the roof of the mouth that is in the form of Rethke's pouch. Whereas this is not the case of posterior pituitary. Posterior pituitary gland, as I did tell you, in general endocrinology, is a neuroendocrine organ, which originates from a neural tissue. Look at the uppermost column of the slide. So posterior pituitary gland originates from floor of the brain, that is from roof of the third ventricle in the form of infundibular diverticulum. So that is why this is called as a neuroendocrine organ. So anterior pituitary is an endocrine organ and posterior pituitary gland is a neuroendocrine organ. How is anterior pituitary gland connected with hypothalamus? Anterior pituitary gland is connected with the hypothalamus through a set of blood vessels called as portal circulation. What is a portal circulation? A portal circulation, what is a portal circulation? So portal circulation is anastomosis between the two adjacent capillary beds is called as portal circulation. Portal circulation is seen in the liver. Portal circulation is seen in the kidney in the form of glomeruli and peritubular capillaries. Portal circulation is seen in some parts of the skin. And portal circulation is also developed in connection of anterior pituitary with the posterior pituitary gland. Now, if you look at this slide, that is the superior hypophyseal artery, enters the median eminence, makes the first bunch of capillaries called as primary plexus. Now, this primary plexus, rather than opening the veins and venules, now forms a secondary network of capillaries called as secondary plexus in cells of the anterior pituitary, and then they join together and the blood leaves by anterior hypophyseal vein. So anterior pituitary gland is connected with hypothalamus by the portal circulation called as hypothalamo-portal circulation. Hypothalamo-hypophyseal circulation. And then there is histology of the endocrine cells of the anterior pituitary gland. Histology of the endocrine cells of the pituitary gland. Now, there are two types of cells in the anterior pituitary gland, chromophobes called as chromophobes and chromophils. 50% are chromophobes and 50% are chromophils. Chromophobe cells, they are agranular cells. They don't have granules, so they don't take up the stain. Physiologically, they are silent and non-secretory cells. But tumors of the chromophores may ectopically secrete ACTH and growth hormone. Whereas chromophilic cells, they are granular cells. They take up the chromic acid stain. And these chromophilic cells are very active. And they are subdivided into two types of cells called as acidophilic cells and basophilic cells. Acidophilic cells and basophilic cells. Now, 35% of the 50% of the chromophils are acidophilic cells, and 15% of basophilic cells of the 50% of chromophils are basophilic cells. Look at this slide. Now, somatotrope cells, which secrete growth hormone, now they occupy 50% of the endocrine cells of the pituitary, and they are acidophilic cells. Lectotrope cells, they secrete prolactin. They occupy 10 to 30% of the total secretory cells, and they are acidophilic cells. So acidophilic cells, they secrete growth hormone and prolactin. Whereas basophilic cells are subdivided into three types: corticotrope cells, which secrete ACTH, and they make 10% of the secretory cells. Thyrotrope cells, which secrete TSH, they make 5% of the secretory cells. Now, gonadotroph cells, which secrete LH and FSH, which make 20% of the secretory cells. So generally questions are also asked, some of the MCQs from endocrinology, from the histology of the endocrine cells of the anterior pituitary gland. Now, what are the functions of the growth hormone? Growth or growth, there are three hormones for which mode of action is very difficult to understand. So they are the growth hormone, they are insulin, that is insulin, growth hormone, and insulin and thyroxine. Thyroxine, growth hormone, insulin, because they've got multiple mode of action. So growth hormone is a glycoprotein hormone. Some of its action are mediated through cyclic AMP, whereas other actions are mediated through synthesis of new proteins and enzymes. When I was making the slides for growth hormonal action, it occurred to my mind which other growth factors are responsible for growth of the human body. So these are the other factors than growth hormone, which are responsible for growth of various parts or tissues of the body. Now, this slide has got three columns: name of the factor, from where it does come from, and what does it do. Now, this epidermal growth factor comes from the salivary and the other glands, and it causes growth of the epidermal and nerve cells. Nerve growth factor originates from tissues innervated by sympathetic neurons, and it causes growth of the sympathetic and sensory neurons. Insulin-like growth factors 1 and 2, which is commonly called as somatomedins 1 and 2, it is secreted from the liver, and it is induced by growth hormone, and it stimulates growth and metabolism. Interleukins, they originate from T cells and macrophage of the immune system, and they are called as autocrine agents for the T cell growth. Similarly, granulocyte macrophage colony stimulating factor, they come from the T cells, endothelial cells, and fibroblasts. And these cells convert TLC into DLC. They cause differentiation of the stem cell for the white blood cell. Differentiation is done of the white cell by them. Transforming growth factors, they come from the embryonic cell, and they act as an autocrine agent for embryonic growth. And then platelet-derived growth factor originate from the blood platelets. They stimulate growth of the connective tissue and smooth muscle in the damaged blood vessels. Let us talk about growth hormone. Growth hormone is a glycoprotein hormone. Some of its fraction is some of its fraction is a protein hormone, and some of its fraction is a carbohydrate, glycoprotein, right? Now look at the factors which will stimulate secretion of growth. That is hyperglycemia. If there's rise in blood sugar level, will inhibit. Fall in blood sugar level will stimulate growth hormone. 2-deoxyglucose, exercise, fasting, like amino acids, protein meals, infusion of amino acids like arginine, and stressful stimuli. Growth hormone is also one of the hormones which is secreted more when there is over prolonged stress or chronic stress. So these are various factors, and going to sleep, especially during the growing age, like L-DOPA, is a monoamine. L-DOPA stimulates secretion of growth hormone. So these are the few factors which will stimulate secretion of growth hormone in humans. And these are certain stimuli which will inhibit secretion of growth hormone. So growth hormone during the growing age, during sleep is much more. But when there is a phase of rapid eye movement, sleep, growth hormone will diminish. So growth hormone is increased during sleep, but it is decreased during REM sleep. Could be a good MCQ. Growth hormone is secretion is decreased, in the following phases of sleep: rapid eye movement, deep eye, the glucose, rise of cortisol, rise of free fatty acids, medroxyprogesterone rise, growth hormone rise, and somatomedin rise in the plasma. they will inhibit secretion of growth hormone. What are the actions of growth hormone? So the main action of growth hormone is chondrogenesis. Chondrogenesis. C-H-O-N-D-R-O, genesis. Chondrogenesis. What do we mean by the term chondrogenesis? That means development of bone, development of teeth, development of cartilages, development of muscle, development of connective tissue, development of stroma, collectively is called as chondrogenesis. So it stimulates chondrogenesis. It stimulates chondrogenesis. So that is why under influence of growth hormone, the bones, muscle, teeth, and body in all dimensions, in height, in width, is increased under influence of growth hormone. But this effect on chondrogenesis is indirect. That is, growth hormone in the plasma affects on the liver cells. From the liver cells, it will secrete insulin-like growth factors 1 and 2, or somatomedians 1 and 2, and these somatomedian 1 and 2 will lead to protein anabolism in the muscle cells, in the teeth cells, in the bone cells, in the cartilage cells, and in the stromal cells. So this is how chondrogenesis is brought about. And then it is a metabolic hormone. Growth hormone is a metabolic hormone. Now, on carbohydrate metabolism, it is an anti-insulin-like hormone. Now, insulin causes stimulation or increase of glucose entry into the cells, whereas this causes decrease of glucose entry into the cell, or decreased glucose uptake by the cells. So glucose stays back in the plasma, causing hyperglycemia. It causes glycogenolysis, breakdown of glycogen into glucose. It causes gluconeogenesis, formation of glucose from non-carbohydrate sources, like from amino acids or from glycerol. So by inhibiting glucose uptake, by stimulating glycogenolysis, by stimulating gluconeogenesis, it is a hyperglycemic and diabetogenic hormone. So this type of hyperglycemia induced by rise of pituitary hormone is called as pituitary diabetes. The pituitary diabetic hormones includes growth hormone, prolactin, TSH, and ACTH. So those hormones of the pituitary which contribute towards hyperglycemia include growth hormone, prolactin, TSH, and ACTH. So effect of growth hormone on lipid metabolism. It affects on the adipose tissue where triglycerides are deposited. It converts triglycerides or breaks down triglycerides into free fatty acids and glycerol. So this free fatty acid in the liver will enter into beta oxidation pathway to form ketone bodies. So it is a ketogenic hormone, like acetoacetic acid, beta hydroxybutyric acid. They are raised in the plasma. So it is a lipolytic and ketogenic hormone. And then it is on the protein metabolism. On the protein metabolism, it is a protein anabolic hormone. It stimulates entry of amino acid uptake by the cells, and then these amino acids join together to form proteins, muscle proteins, liver proteins, bones proteins, like connective tissue proteins, and so forth, glycoproteins, nucleoproteins, and so forth. So it is a chondrogenic, let us do the poetry in endocrinology. It is a chondrogenic, hyperglycemic, diabetogenic, lipolytic, ketogenic, and a protein anabolic hormone, right? And then let us look at this composite slide. How is growth hormone secretion regulated, like physiologically, and what are its actions in a tabular or in a flowchart form? Like, look at the somatotroph cells of the anterior pituitary in middle of the column of the slide. These are the cells which are acidophilic cells of the anterior pituitary to secrete growth hormone. So look at the brain. Adrenergic stimulus, alpha receptor stimulate, beta receptor inhibit, hypothalamic GHG, growth hormone releasing factor, which will stimulate somatotrophs of the anterior pituitary to cause secretion of growth hormone in the plasma. Growth hormone in the plasma on carbohydrate metabolism will lead to glycogenolysis, and decrease cellular uptake of glucose, causing elevated blood glucose level. And then this growth hormone will affect on the adipose tissue and will cause breakdown of the deposits of fat, like leading to rise of ketone body, free fatty acids, and leading to ketone bodies. And like look at the growth hormone increases cellular uptake of amino acids to cause protein anabolism. And rise of growth hormone affects on the liver to form somatomedin 1 and 2, which will bring about metabolic effect or protein anabolic effect, and rise of somatomedin, a rise of growth hormone in the plasma through negative feedback system would inhibit hypothalamic cell to inhibit GRH to bring it back to normal. So this hormone, growth hormone, is regulated by hypothalamo-pituitary axis, like by a negative feedback system through an hormonal interplay, but this axis is influenced by exogenous and endogenous stimuli. Exogenous stimuli like stress, physical and psychological, like stress, whether physical or psychological, will modulate the rate of secretion of growth hormone, and change in homeostatic balances within the body would stimulate or inhibit rate of secretion of growth hormone. Right. Now, my way of teaching would in endocrinology would be, I will give you the basic picture first of physiology regarding that endocrine cells or gland, and then I will try to build up the pattern of applied or clinical physiology on it. Now, this was the knowledge, but how this knowledge is put into practical use or clinical use for the betterment of the patient diagnostically. Now, these are as we say, thyroid function tests or liver function tests or renal function tests. Like similarly, let us have a few words about pituitary function tests. Pituitary function tests to evaluate hormones of the hypothalamo-pituitary axis named after the gland. That is growth hormone test, prolactin test, gonadotropin test, TSH test, ACTH test. But let us pick them up one by one. And first test is growth hormone. If a patient reports to your clinic, you ascertain him that he has got some endocrine defect. And then you further ascertain that he has got some effect of the pituitary. And then you further ascertain probably he has got some defect in growth hormone. So then which tests he or should be exposed to? That is, these are the tests. If you suspect growth hormone to be deficient from his clinical picture, now you will order plasma growth hormone, insulin-induced hypoglycemia, L-DOPA stimulation test, arginine infusion test, and exercise glucose or pitocin test. Now, of course, plasma human growth hormone will be increased in hypopituitarism and will be decreased in hypopituitarism. Insulin-induced hypoglycemia is not done now, like it is obsolete test now, but theoretically, like when insulin is given, it causes hypoglycemia, and that stimulates secretion of growth hormone in the plasma. If this fails to increase growth hormone in the plasma, so that means hypopituitarism. Like L-DOPA is a monoamine. Now, L-DOPA is given in calculated doses to the patient. Like it physiologically, it stimulates secretion of growth hormone. Failure of stimulation of growth hormone in response to L-DOPA would mean hypoactivity of the somatotroph cell. Arginine is an amino acid which stimulates secretion of growth hormone. Like failure of rise of growth hormone in response to L-arginine would mean hypoactivity of the somatotroph cells. Now, growth hormone excess test is glucose tolerance test. Glucose tolerance test. Now, as we do glucose tolerance test, now save some Elicor. Right, glucose tolerance test. Glucose tolerance test, as we do it, that is fasting, 12-hour fasting, blood glucose level. Person is given 75 to 100 gram ingestion of glucose, and then is after half 1 hour or 2 hours, 3 hours estimated. Similarly, when we have got fasting blood glucose growth hormone, it will be in the lower limit of the normal range physiologically. And when we give him breakfast or 100-gram ingestion of glucose, after that it will rise. But failure of rise of when they give him 100-gram ingestion of glucose, growth hormone should tend to fall. Now, suppression of fall, if it fails to fall, so then it means he has got ectopic secretion of growth hormone, or there is some tumor of the somatotroph cells of the anterior pituitary gland. Similarly, ACTH, another hormone of the anterior pituitary. Now, if you think some person, like whether he has got Cushinard features or adrenocortical insufficiency, ACTH secretion test. Meteropone is a drug which is selectively given in patients of Nelson syndrome to inhibit secretion of ACTH. Failure of suppression of ACTH would mean tumor of the corticotroph cells of the anterior pituitary or some ectopic secretion of ACTH. Similarly, insulin-induced hypoglycemia will stimulate ACTH. Failure of stimulation of ACTH would mean hypopituitarism. CRH stimulation test. Now, if it is a tertiary form of hypocortism, so then he will be given CRH stimulation test to cause rise of ACTH and rise of ACTH. Failure to cause rise of ACTH would mean confirmation of the tertiary form of hypercortism. But we will discuss these function tests when we talk about in the next session tomorrow, when we talked about adrenal cortex. Now look at here, prolactin secretion test, prolactin secretion stimulation test. TRH, thyrotropin releasing hormone, in physiological amount stimulates TSH, but in pharmacological dosage, it also stimulates secretion of prolactin. If TRH is given in pharmacological dose, if it fails to cause hyperprolactinemia, so that means hypoactivity of lectotroph cells of the pituitary. Metoclopramide is a drug which stimulates prolactin physiologically. Failure of rise of prolactin in response to metoclopramide would mean hypoactivity of the lectotroph cells. Insulin-induced hypoglycemia, will stimulate rise of prolactin, but failure of rise of prolactin would mean hypoactivity. Similarly, prolactin secretion suppression test. Bromocriptine is a drug which suppresses prolactin. Now, in infertility cases, bromocriptine in selective cases advised to inhibit hyperprolactinemia to lead to the female to become fertile, and even lead to the male to be fertile as well. Hyperprolactinemia is one of the causes of male and female substerility or sterility. So bromocriptine suppresses prolactin. If it fails to suppress prolactin, so that means it is prolactinoma. L-DOPA is a monoamine which stimulates growth hormone, but L-DOPA inhibits secretion of prolactin. L-DOPA is given, prolactin is suppressed normally. But if it fails to suppress, it still remains elevated, so that will mean prolactinoma, a tumor of the cell. So we will talk about it in a while when we talk about thyroid function tests in detail, but here plasma T3, T4, plasma free T4. Now total T3, T4 is not done. It is the free form of T4 or T3, which is estimated because in general endocrinology we learned it is the free form of the hormone which is biologically active. And then is plasma TSH and TRH. Jigsaw puzzle between TRH, TSH, and T4 which give us the clue whether he or she is a case of primary hypothyroidism, secondary hypothyroidism, or tertiary form of hypothyroidism. And then is TRH stimulation test. Interpretation of this test we will learn today in a while when we talk about thyroid hormone. Similarly, gonadotropin tests. Like, don't worry, plasma EP, testosterone, LH, and FSH. So, and the jigsaw puzzle of the hormone at hypothalamo-pituitary gonadal axis. Hypothalamo-pituitary testicular in male, hypothalamo-pituitary ovarian axis in the females. See, we can work it out whether he or she is case of primary hypogonadism or tertiary hypogonadism or secondary hypogonadism. If we suspect to be a case of tertiary hypogonadism, then we give him GnRH stimulation test. A calculated dosage of gonadotropin-releasing hormone is injected, and then and then is testosterone in male or estrogen in the female if estimated. If it rises in the plasma, it confirms that this hypogonadism was due to hypothalamic failure. Clomiphene is a drug which selectively suppresses LH and FSH. Like failure of suppression of LH and FSH would mean ectopic secretion of gonadotropin or tumor of the cell. So far, these function tests were based on the hormonal assays, right? But there are certain adjuvant tests. There are certain adjoining tests which they don't diagnose, but they aid in diagnosis. They help in making the diagnosis, and they are non-hormonal tests. For example, X-ray of the hand and feet. If a baby comes to you, his growth is stunted, so you do X-ray of hands and feet. If a 12 years old boy or a girl shows bone and hands, feet and hand, age of 5 years of age, so that will give us a clue that he has got some pituitary dysfunction. X-ray of the skull of the pituitary gland to know the pituitary atrophy or hypertrophy. And visual field examination. Now, in acromegaly cases, like it leads to diplopia. Why diplopia? Because sella turcica, we know pituitary gland lies on the bone of sella turcica, like at the level of the optic crossing, visual pathway, crossing of the visual pathway. So when this bone sella turcica grows, like visual field is disturbed, and it leads to diplopia in acromegaly cases. And then we do computerized tomographic scanning, that is CT scan of the brain, of the thyroid, and of the adrenal to know the level of the lesion. As we do cardiac angiography, arteriocardiac or cardiac of the anterior pituitary gland or hyperemia of the blood vessels. If it is low blood, it will lead to ischemic changes. If it is more blood, it will lead to hyperemia of the endocrine defect. And then is disorders of the anterior pituitary, hyperpituitarism, that is jointism. In children, if it occurs before the union of epiphysis with the shaft of the long bone, it will lead to jointism. Like hand, feet, a joint. The person height, maybe even 7 feet or even higher than that, and his metabolism, look at hyperglycemia, aminoacidemia, free fatty acidemia, like ketonemia would occur. And these individuals generally don't survive more than 40, 45, or 50 years of age because their cells, because of increased rate of metabolism, they burn out the influence. And adults, this is less common if it occurs in adults. So height cannot grow fast. Then person can't become more taller because the epiphysis or the growing points of the bone have been united with shaft of the long bones. But it will be hyperglycemic and free fatty acidemic, and ketonemia would occur. And hands, feet, and scalp, and the chest bones, and the shoulder girdles, the pelvic bones, they will continue to grow, like acromegaly. Features are not as severe as in case of jaundice. And it is case of Cushing disease. Now, right? He has got a plasma picture of a hormone. He has got rise of ACTH and rise of cortisol, showing Cushingoid features. And his blood picture, hormonal picture, is rise of ACTH and rise of cortisol. So this is a case of Cushing disease, right? So that means Cushingoid features due to hyperpituitarism. Cushingoid features due to hyperpituitarism is Cushing disease. Another patient reports to your clinic, he has got rise of cortisol in the plasma, but fall of ACTH. So this patient, and showing Cushingoid features because rise of, he has got fall in cortisol, and rise in ACTH, So this is a case of Cushing disease. So Cushing disease is adrenocortical in origin. Cushing syndrome is adrenocortical tumor, and Cushing disease is a pituitary tumor or ectopic ACTH secretion. But clinical features in both type of patients will be the same. Hypopituitarism is more common than hyperpituitarism. Now, most common of hypopituitarism is dwarfism. If undergrowth if dwarfism, if it occurs for children, it is called as dwarfism. Dwarfism is a two types, Laron and Bissau type of dwarfism. Laron type of dwarfism is growth hormone is normal, but still the person is short-stunted. Why? Because somatomedians are reduced. So there is down regulation of growth hormone receptors, like on the liver cells, leading to fall in somatomedians. So growth hormone normal are raised, somatomedians low, person showing stunted height is a Laron type of dwarfism. If growth hormone is low, somatomedians are low, this is Bissau type of dwarfism. And please mind, there are three types of development, physical, mental, and gonadal, which matter. Here, the baby is short-stunted, but all the parts of the body, that is limbs and muscles of the body, they are proportionately smaller. Stunted height, but proportionately smaller, does not give an ugly look. Mentally, he is normal. Growth hormone has little to do with development of the neuronal cells. IQ of the baby is normal, and from gonadal, he has got sexual infantilism. That is a boy of 15 years of age, may be showing the size of the gonad as 4 or 5 years of age. Sexual infantilism, IQ normal, short-stunted, but does not give an ugly look, is a case of dwarfism. Opposite, now then, if it occurs in the adults, that is called as acromicra. Acromicra is very, very rare. 1 in a million patients may be detected, and the features are not so prominent because if growth hormone is brought at 0 level, after the onset of puberty, no untoward effect will be seen in the body because growth is permissively carried out by insulin secretion, by thyroxine, and by cortisol. So it is not the initiation after the onset of puberty, it is only maintenance of the growth which is important. And then is Frolic syndrome. In Frolic syndrome, what happens? Growth hormone as well as TSH is deficient. Growth hormone as well as TSH hormone is deficient. So the features would depend whether the poor victim is a child or a poor victim is an adult. If the poor victim is a child, this condition is called as adipose-genital dystrophy. Adipose-genital dystrophy means a patient reports to your clinic, he is obese, adiposity. He is obese, he is physically, gonadally, and mentally subnormal. So probably he is a child type of Frolic syndrome. If the poor victim is an adult, the features would depend whether the poor victim is a male or a female. If the poor victim is a male, it will lead to feminization of the masculine features. If the poor victim is a female, it will lead to over-feminization of the female, over-shyness, over-deposity of fats on certain regions of the body. And then a rare condition of hypopituitarism is Lawrence-Moon-Beadle syndrome. These were the three scientists, Lawrence, Moon, and Beadle, like syndrome. So in this type of hypopituitarism, it is growth hormone, like it is TSH as well as ACTH. Growth hormone, TSH, and ACTH, they are deficient. Which features would it lead to? All the features of child type of Frolic syndrome, that is adipose-genital dystrophy, superadded with polydactyly, 5 or 6 fingers or toes, 6 or 7 or more, like polydactyly and retinitis pigmentosa. So features of adipose-genital dystrophy superadded with polydactyly and retinitis pigmentosa is a case of Lawrence, Moon, Beadle syndrome, and pathophysiology is fall in growth hormone, fall in TSH, and fall in ACTH. And then if all the hormone of the pituitary, if pituitary atrophy occurs, it will lead to pan-hypopituitary. Pan means all over deficiency of the hormones of the pituitary gland. If it occurs in the children, it is called as progeria. If it occurs in adults, the condition is called as Simmons disease. If it occurs due to excessive postpartum at the time of delivery, postpartum hemorrhage leading to acute anterior pituitary necrosis, so then this condition is called as Sheehan syndrome. Sheehan syndrome. So all the conditions of pan-hypopituitarism like are associated with features, all the features of hypothyroidism, all the features of hypocortism, all the features of hypogonadism. Life, if not impossible, will be extremely miserable in such patients. Now, a few words about the posterior pituitary gland. Posterior pituitary gland is a neuroendocrine organ because we have seen embryologically it takes its origin from the neural portion, that is from the floor of the brain, floor of the third ventricle in the form of infundibular diverticulum. As you can see in the slide, supraoptic nucleus, like supraoptic nucleus of the hypothalamus secretes ADH, and its axons come through the pituitary stalk and go to the cells of the posterior pituitary gland called as pituocytes. Paraventricular nucleus arises from the brain, causes secretion of oxytocin. Now this is released into the axon and goes to the pituocytes. The beauty of these axons is on its pathway, they secrete special protein granules called as neurophysin. So these neurophysin protein molecules in the axons, they combine with ADH molecule and gives it the storage property. Please mind, hormones generally, they are not stored in the body. They're not stored in order to avoid cumulative effect. But there are certain exceptions to this rule, and the main exception is of thyroxine. Thyroxine can be stored in the body or tissues for about 4 to 6 months. So that gives one clinical picture that when a clinical hypothyroid patient comes to you, biochemical hypothyroidism might have occurred 4 to 6 months earlier, right? So this lag period between taking water and voiding the urine, so this lag period is because of the stored quantity of ADH, utilization of the stored quantity of ADH. When they get depleted, then we get desire to void urine, right? So hypothalamus is connected with posterior pituitary gland through nerve bundles or nerve tract, and this is called as hypothalamo-neurohypophyseal tract. Hypothalamo-neurohypophyseal tract. Which are the factors which regulate secretion of ADH from the hypothalamus or posterior pituitary gland? First of all is plasma osmolarity. You know it is 300 milliosmoles per liter. If there is rise of plasma osmolarity, if we take too much of sodium chloride or we take too much of glucose or colloid particles, so plasma osmolarity or tonicity will rise in the plasma, right? So this will be detected by the hypothalamic detectors, osmoreceptors. Like, so rise of plasma osmolarity than 300 milliosmoles per liter is detected by hypothalamic osmoreceptors, sensor cells, which will stimulate secretion of ADH. ADH will be more released from the pituocytes, it will circulate in the plasma and will come to the kidney, will affect on V2 type of receptors through cyclic AMP system to cause anti-diuretic effect, like to conserve more quantity of water to maintain tonicity or osmolarity of the plasma. So the first most important factor to regulate ADH secretion is plasma osmolarity or plasma tonicity through hypothalamic osmoreceptors, right? And then is the volume receptors. Where are volume receptors located? They're located in the right atrium and in the large arteries. They are stretch receptors. If we take too much of bucket of water or over infusion, like of sodium chloride or glucose, like what will happen? Hypervolemia would occur. Now this will lead to stretch of the right atrium and the large arteries, and they will suppress, they will inhibit in supraoptic nucleus of hypothalamus to cause inhibition of ADH and to cause more excretion of urine. So the second factor to regulate is volume receptors located in the right atrium and in the large arteries. The third stimulus is through the baroreceptors, pressure receptors. So they are located in carotid sinus and aortic arch, and they are very sensitive to hypotension of hypovolemic in origin. They're very sensitive to hypotension of hypovolemic in origin. So hypotension of hypovolemia will stimulate like carotid and aortic baroreceptors and will stimulate supraoptic nucleus of hypothalamus to secrete more ADH, and to conserve more quantity of water to overcome hypovolemia. And then there are certain drugs like water, alcohol, and other drugs which will directly inhibit supraoptic nucleus of hypothalamus to cause inhibition of ADH and to cause more excretion of urine. And there are certain neurological stimuli, that is pain, emotional, and stress stimuli, which by unknown visceral efferent pathway may change the rate of secretion of ADH. Sometimes there is a direct MCQ. These are the factors which may stimulate, and these are the factors which may inhibit secretion of ADH. On your left-hand side with the yellow color are the factors which will stimulate secretion of ADH. So they are increased effective osmotic pressure of the plasma. In fact, if you look at them, 2 MCQs directly are written on the slide, like increased effective osmotic pressure of the plasma, decreased extracellular fluid volume or hypovolemia, pain, emotion, stress, severe exercise, nausea and vomiting for OBG groups of obstetric hyperemesis gravidarum, administration of drugs like now we are talking of physiopharmacology now, pharmacological drugs like morphine, nicotine, barbiturates, chlorpropamide, clofebrate, carbamazepine, and angiotensin, they will stimulate secretion of ADH. So those factors which inhibit secretion of ADH and cause increased urinary volume excretion include, shown with the white color on your right-hand side. That is decreased effective pressure of the plasma, or hypovolemia, or hypotension, or hypovolemia, or negative water balance, or dehydration, like increased extracellular fluid volume. Alcohol. Now, alcohol, people consume alcohol and they avoid urine because of suppression of ADH. And then the drugs, butorphanol and exolorphan. So water, alcohol, butorphanol, and exolorphan, they inhibit secretion of ADH and they cause more. And now then is if ADH, you can't see the slide, but there's no need. I will talk about the keywords for you. So diabetes insipidus is a condition which is characterized with decreased ADH secretion. If ADH secretion is below normal, person will avoid more urine, and it is called as diabetes insipidus. So diabetes insipidus pathophysiology, it could be neurogenic. In 85% of cases, the cause is neurogenic. In only 15%, the cause is nephrogenic. Neurogenic, something wrong with the brain cells, something wrong with the secretion of neurotransmitters, something wrong with the hypothalamus, something wrong with the hypothalamic neurohypophyseal tract, something wrong with the cells of the posterior pituitary gland is neurogenic diabetes insipidus, which is 85%. 15% is nephrogenic. ADH secretion is normal, or even it may be more than normal, but there is downregulation of ADH receptors on the renal tubule, on the collecting duct. So that's ADH effects, but its actions are blocked because of receptor blockade. That is called as nephrogenic diabetes insipidus. And then there could be syndrome of inappropriate ADH secretion. Syndrome of inappropriate ADH secretion, if there is a tumor of the supraoptic nucleus of the hypothalamus, ADH will be much more secreted, so there will be overcirculation. All the features of circulatory overload and hypertension would appear in a patient of syndrome of inappropriate ADH secretion, SIADH. Now, as we talked about anterior pituitary function tests, let's have a few words about posterior pituitary function tests. So diagnose on the basis of the principles of physiology. ADH will be low in diabetes insipidus. ADH will be more than normal in SIADH secretion. Water deprivation test, like person is deprived of water. That's it. In the month of fasting, while fasting for 12 hours, right? So while fasting for the month of 12 hours, now if the end of the 12 hours, like if we take the blood sample, if you deprive a person from 12 hours of fasting, not taking water at all, water deprivation, and the food, water deprivation. So after 12 hours, take the plasma sample and estimate the ADH. ADH level should be in the upper limit of the normal range. If ADH level remains in the lowest limit of the normal range, so that means this indicates a case of diabetes insipidus. Opposite to this is water load test. Person is taken 1 liter of water altogether, right? And after some time, after say 2 hours, his plasma sample is taken and estimated in the plasma. What do we suspect in normal persons? In normal person, ADH level should be in the lowest limit of the normal range. But if in a patient, it still remains elevated, so that indicates a case of syndrome of inappropriate ADH secretion. X-ray of the skull to know hypertrophy or atrophy, CT scan of the brain, and arteriography to the blood vessels of the hypothalamus and blood vessels to the anterior pituitary gland, right? So we have talked about what we have talked about so far. We have talked about the general principles of endocrinology, and based on that, we switched on to systemic endocrinology, and we talked about hypothalamus as a neuroendocrine organ, and we discussed like basics and applied pathophysiological underpinning principles of the anterior pituitary and our posterior pituitary. So this is the last topic of today, and then we'll call it a day for tomorrow, is the thyroid gland. At the end of the thyroid gland, I'll give you 10 minutes to ask a question. So please make a question very much to the point, pertinent, specific, with economy of words. Right. Thyroid gland, as we know, if you feel in the upper surface now of the neck, in front of the neck, you feel some structure. This is not subcutaneous tissue. This does not look like fat. This is some form of a diffuse structure on both sides of the trachea. This is called as a thyroid gland. So thyroid gland secretes 2 types of hormones, peptide hormones like protein hormones, and then is amino acid derivative hormones. Amino acid being tyrosine. I did tell you in my introductory lecture today that tyrosine is a common precursor for secretion of T3, T4, adrenaline, and noradrenaline. Of course, for T3, T4, it is iodinated tyrosine as a precursor for secretion of T3 and T4. And then there is a peptide hormones. Now these are called as thyroid follicular epithelial cells. So T3 and T4 is secreted from thyroid follicular epithelial cells. Whereas outside the follicles, there are certain C cells are called as parafollicular cells, which secrete protein hormone called as calcitonin. So parafollicular or C cells outside the rim of the thyroidal follicle, they secrete calcitonin, which is a peptide hormone, whereas from tyrosine or from iodinated tyrosine, thyroid follicular epithelial cell, they secrete triiodothyronine, T3, and tetraiodothyronine, which is T4. T3 and T4, they circulate in the plasma, mainly in bound form, mainly bound to globulin. And this shows the peripheral circulation of T4. Either it is bound to TBG, or in a free form, it exerts its physiological response at the target tissue, or there occurs peripheral conversion to T3. Now look at it. Now look at this slide. Now look at this slide. The difference of transport of hormones T3 and T4 in the plasma. If we look at thyroid binding globulin, TBG, now 67% of thyroxine and 46% of T3 circulates in the plasma bound to globulin plasma protein. Combination is called as TBG. And look at TBBA, thyroxine binding pre-albumin. 20% of T4 and almost nil or 1% T3 circulates in the plasma in bound form to pre-albumin. And look at albumin. Like albumin, 13% of T4 and 53%, of T3 circulates in the plasma in bound form to pre-albumin, and the combination is called as TBA, thyroxine binding albumin. So that means thyroxine circulates mainly in bound form to globulin, whereas T3 mainly circulates in the plasma in bound form to albumin. But it is the free form which is biologically active. Now, some actions of the thyroxine, metabolic actions, they are mediated through cyclic AMP system, but mainly its actions are not mediated through cyclic AMP system. They are mediated through synthesis of new proteins and synthesis of new enzymes. And T3 and T4 has got nuclear receptors in the target cells. Now, this is a slide of combination. This is a slide of combination of physioclinical slide, the functional slide and their clinical features if they get disturbed, this slide. Now look at the foremost effect of, as I said, that foremost effect of growth hormone is chondrogenesis and then our metabolic actions. Similarly, the foremost effect of thyroxine is called as calorigenesis. Calorigenesis is also called as heat production, or calorigenesis is also termed as thermoregulation. Now, about 60% of thermoregulation of the body, which means 98.4 basal body temperature, 60% of this body temperature, is brought about by the intactness of the thyroid gland. If total thyroidectomy is done, the body temperature will tend to fall. That is why even if when total thyroidectomy is advised, they leave a still bit of it, partial thyroidectomy is preferred. So calorigenesis, heat production, or thermoregulation. So there are three thermoregulatory hormones. Main important is thyroxine, and then is adrenaline to some extent, and then is progesterone, but during early post-ovulatory phase. So thyroxine, main thermoregulatory hormone, adrenaline, progesterone only during the early post-ovulatory phase are the thermoregulatory hormone. How does it bring about? What is calorigenesis? If you look at it, when ATP is utilized, it is converted to ADP, inorganic phosphorus, capital P, small I, and then capital E is liberated. This E is liberal form of energy. So it is the free or the liberal form of energy which produces heat or warmth in the body, giving to basal body, core body temperature. So that is ATP. Look at ATP. Now it uncouples. We don't know exact mechanism of thyroxine to bring about calorigenesis, but mainly it is by uncoupling oxidative phosphorylation reaction. Uncoupling of oxidative phosphorylation. And then it stimulates sodium, potassium, ATPase system. And then it increases oxygen consumption of the tissues per unit time. So this heat production or thermoregulatory effect brought about by thyroxine is by uncoupling oxidative phosphorylation biochemical reactions, by stimulating sodium, potassium, ATPase system, and by stimulating oxygen consumption of the tissues. But then the question is, do all cells require thyroxine for calorigenesis? The answer is no. There are certain exceptions. Then the question comes, which are the exceptions? Which are those cells which do not require thyroxine for calorigenesis? So they are the brain cells, they are anterior pituitary cells, they are lymph nodes, they are spleen, they are uterus. So brain cells, anterior pituitary cells, lymph nodes, spleen, and uterus are independent of thyroxine for the process of thermoregulation. So then it's a metabolic hormone, its effect on carbohydrate metabolism. It leads to decreased oxygen glucose uptake. It leads to glycogenolysis, breakdown of glycogen into glucose, and there is impaired intestinal glucose absorption, so leading to hyperglycemia. This form of hyperglycemia induced by hyperthyroidism is called as thyroid diabetes. Thyroid diabetes. As far as it affects our lipid metabolism is concerned, it is a lipolytic hormone. It breaks down triglycerides in the adipose tissues and converts them into free fatty acids, And glycerol, this free fatty acid and glycerol will enter into gluconeogenic pathway. Sorry, this free fatty acid in the liver cells will enter into beta oxidation pathway to form ketone bodies. So it is a lipolytic and ketogenic hormone. But look at the plasma cholesterol. There's high plasma cholesterol in hypothyroidism. There's low plasma cholesterol in hyperthyroidism because thyroxine breaks down the molecule of cholesterol into its components. So there's hypercholesterolemia in hypothyroidism. There's hypocholesterolemia in hyperthyroidism. And the protein metabolism effect of thyroxine is bifold, dose dependent. In very low doses, it causes protein anabolism. But in moderate to high doses, it causes protein catabolism. And this decreased protein synthesis, and now superadded with water accumulation, leading the subcutaneous tissue from water to gel form due to deposition of proteins, glycoproteins, will lead to non-pitting type of edema. And that is the one of the characteristics of mixed edema, which is mixed edema is a condition of hypothyroidism in adults, more common in the female. In very hyperthyroid situations, there is protein breakdown leading to negative nitrogen balance. Look at the growth hormone. So there is deficient growth at certain ages. If from the mother, this TSH does not come from the mother, or T4 does not come from the mother, to the fetus, there's deficient growth at certain age. But whether administration of T4 will stimulate the growth in a baby, we don't know. It is not well documented. But its deficiency leads to cretinism. Now, its effect, we have seen that growth hormone endorphism has got little to do with development of the brain. But this is not with the case of the thyroid. So myelination of the nerve fiber and certain parts of the hypothalamus and of the hard brain, they require thyroxine fermentation, myelination of the nerve fiber, which converts point-to-point propagation of the impulse cell to saltatory conduction, jumping from node to node conduction. So that is why in hypothyroid situation, so there is sluggish mentation. And there is restlessness, anxiety, irritability, insomnia in case of hyperthyroid situations. And look at the cardiovascular system. It is said that thyroxine causes upregulation of catecholamine, especially adrenaline receptors on the adipose tissue and on the cardiac tissue. So that means adipose tissue and cardiac tissue. So that is why bruism thyroxine will lead to rise of adrenaline, which will lead to increase in heart rate, decreased cardiac output, and increase in circulation time in hypothyroid situations. In hyperthyroid situations, like hyperthyroid situations, where T4 is more, there will be increase in heart rate, increase in cardiac output, and decrease in circulation time. Look at here, heart under influence of thyroxine will have positive chronotropic effect. Adipose tissue catabolic actions stimulates lipolysis. Muscle catabolic actions will lead to protein catabolism. Bone, it has got development of bone, skeletal, and cartilages. Nervous system, it has got development of the myelin fibers, myelin sheath of the nerve fibers and certain parts of the brain. And gut increases carbohydrate absorption and lipoprotein formation of LPL receptors and calorie genesis, all right? Calorie genesis, but calorie genesis have got exceptions on the testicular cells, on the uterus, on lymph nodes, on spleen, and anterior pituitary cells. Right. About this slide, so this slide is not visible to you, but this shows the principle of primary, secondary, and tertiary hypothyroidism, which we will study just now by leading to thyroid function tests, like thyroid function tests. Total T4 and T3, but this is not done now as a routine. Now it is free T4 and free T3. Why? Because it is the active form of the hormone which is biologically active. And then is reverse T3. Reverse T3 so far is biologically inactive compound. But reverse T3 increases in certain conditions like chronic fasting, chronic illness, hypercortism in fetal life. In fetal life, hypercortism, chronic illness, like this reverse T3 is said to be raised. But what does it do? Reverse T3, we don't know the actions because so far it is said to be biologically inert. And thyroglobulin and protein-bound iodine, they are decreased in hypothyroidism and they're increased in hyperthyroid situations. And then there are certain tests on the thyroid gland, radioactive iodide uptake test. This test is obsolete now, because it involves radioactive iodine 125 or iodine 131. So that means radioactive iodine is given, it is actively transported from the plasma into the thyroid follicular epithelial cells to estimate and we see the radiation rays. If there's more radioactive iodide uptake test, so that means hyperthyroidism. If there's less radioactive iodide uptake, it means hypothyroidism. Thyroid scanning to know the hot and the low areas, hot areas of the nodules. And then is ultrasonography. These are the tests, they are not confirmatory tests. They help in diagnosis. BMR is not done now because it is virtually impossible to be at a state of physical and mental basal condition now. And it requires a lot of equipment, very expensive, require expertise. But academic reasons like BMR is raised in hyperthyroidism and BMR is low in hypothyroid situation. Achilles tendon reflexes, ankle jerk. Ankle jerk is sluggish and slow down and reflex arc time is delayed in hypothyroidism. But it is not that brisk in case of hyperthyroidism. So Achilles tendon reflex is delayed, sluggish, and reflex arc time is more exaggerated in hypothyroidism. It is not that brisk in hyperthyroid situation. Look at ECG. ECG RR interval in hypothyroid situation, RR interval which denotes the one heart rate, RR interval is prolonged in hypothyroidism. RR interval is reduced in hypothyroidism. And then P wave will be changed with fibrillatory wave in thyroid storm because thyroid storm would lead to atrial fibrillation. So atrial fibrillatory changes, which are denoted by change of P wave of the ECG with the fibrillatory or the F waves. And then biochemical changes, blood glucose, hyperglycemia and hypoglycemia, hypocholesterolemia in hyperthyroid and hypercholesterolemia in hypothyroid situations. And creatinine phosphokinase and lactate dehydrogenase enzyme, they tend to be raised in hyperthyroid situations. These are the tests which are now done much more, like evaluation of hypothalamic thyroidal axis. What is done now, free T4, and then is TSH superadded with the clinical picture of the patient. If you get some clue, fine. If not, then a nodule is taken by the histopathologist and for its biopsy. Now, TSH and TRH. I did tell you earlier today that if T4 is low, TSH is raised, TSH RH is variable, it is a case of primary hypothyroidism. If there is fall in T4, fall in TSH, rise of TRH, it is a case of secondary hypothyroidism. If it is fall in T4, fall in TSH, fall in TRH, it is a case of tertiary hypothyroidism. If it is a case of secondary hypothyroidism, right, and you want to confirm it, now then he or she is exposed to TSH stimulation test. A known dose of TSH is given to the patient, and then after a certain period of time, T4 is estimated in the plasma. If T4 rises in the plasma, that confirms this is case of pituitary insufficiency, pituitary atrophy. And if it is a tertiary hypothyroidism, then this patient, tertiary hypothyroidism, then he is subjected to TRH stimulation test. So this is the interpretation of TRH stimulation test. Look at the normal test, which is written as normal here in the middle curve of the slide. So a known dose of TRH is given, and after a certain period of time, TSH is estimated from the plasma. In a primary hypothyroidism, basal TSH is very high, and there is exaggerated response to TSH secretion in response to TRH. And in a thyrotoxic patient, there's no net rise in TSH secretion in response to TRH. And then is LATs or EPS or TSI. In a thyrotoxic patient is an autoimmune disease. Like, which is the autoimmune? Another abnormal protein. It is not due to rise of TSH. It is not due to rise of TRH. They are even below normal because of negative feedback system. Then what is the persistent cause of rise of T4 in a thyrotoxic patient? The cause is TSI, thyroid stimulator immunoglobulin. It is an abnormal protein. It is detected in the plasma, and this abnormal protein, because it is immunoglobulin, so this is an autoimmune disease. Many of the patients, not all, but many of the patients of thyrotoxicosis, they show a feature of exophthalmos, that is protrusion of the eyeball with lid lag. So that exophthalmos features in a thyrotoxic patient is due to presence of another abnormal protein in the patient that is called as EPS, exophthalmos producing substance. Exophthalmos producing substance. So thyrotoxicosis is an autoimmune disease, and its pathophysiology is due to presence of TSI in the plasma. And exophthalmos feature of a thyrotoxic patient is due to presence of a abnormal protein called as EPS, exophthalmos. If we don't get much clue of the thyroid disease, so that a chunk of the thyroid gland is taken and then it's sent to the laboratory, whether it is normal or abnormal. If it is abnormal, it is thyroiditis or it is a tumor. If it is a tumor, whether it is a benign or it is a malignant. If it is malignant, now which type of malignancy does it provide, and to which drugs or modes of treatment would it respond to? So hyperthyroidism is of three types: thyroiditis, inflammation, tumors, and thyrotoxicosis, which we have just talked about. Right. Look at here, common causes of thyrotoxicosis. When there is diffuse enlargement of the thyroid gland and person is showing toxic features, so this form of thyrotoxicosis is called as Graves' disease. If there are multiple nodules of the thyroid gland and person shows toxic features, so this form of thyrotoxicosis is called as Plummer's disease. If there is a single nodule and person shows toxic feature, this form of thyrotoxicosis is called as toxic uninodular goiter or toxic adenoma. If T4 is normal, but T3 is abnormally raised and person is showing toxic features, so then this is called as T3 toxicosis, but features in all these conditions will be the same. Now, hypothyroidism, if it occurs at the time of birth, prenatal, the person is cretinous. There's short-stature height of the individual, and all the parts of the body, limbs and muscles, they're disproportionately smaller, and it gives an ugly look. Now, open mouth, now protruded tongue, salivation, and mentally, he has got low IQ because myelination and development of certain parts of the brain has been compromised. And then sexual infantilism. Now, then is hypercholesterolemia, hypoglycemia, and if it occurs in children, it is juvenile form of hypothyroidism. The features are very less severe, and if it is detected early and given treatment with thyroxine, now this is a curable condition in children. But if it occurs in adults, female are more prone to have myxedema. It is called as myxedema. Now, neural deficiency, forgetfulness, even doing the normal arithmetic problems, and then there is edema from conversion from pitting to non-pitting type of edema, and hypoglycemia, hypercholesteremia, and many other features would develop. This is the last slide of today, physiopharmacological slide, and I love this slide because this is made easy. Now, biosynthetic pathway of thyroid hormone is blood iodide is by active transport enters into thyroid follicular epithelial cells and is called as thyroid iodide. It is oxidized by hydrogen peroxidase and is converted to thyroid iodine. And this thyroid iodine gets combined with tyrosine, in the colloid substance to form monoiodotyrosine, and diiodotyrosine. This is called as organification or called as hybridization of tyrosine. This mono and diiodotyrosine, they get coupled together to form triiodothyronine, T3, or tetraiodothyronine, T4, or thyroxine. So this upper column of the slide shows the made easy steps of biosynthesis of the thyroid gland. And in the lower column of the slide, blocks shows the pharmacology. So certain factors or drugs like perchlorates, pertechnicates, thiocyanates, dinitrophenol, cyanides, anoxia, excessive iodide like Lugol's iodine drops. Now, two cytotoxic drugs like dimethylcycline and lithium carbide, they block active transport of iodide. They block uptake of iodide. They block iodide pumping. So plasma thyroid does not enter into the thyroid follicular from thyroid follicular epithelial cell. So they act as anti-thyroid substances, like anti-thyroid substances. So they block thyroid biosynthesis right at the first step of iodide pumping or active transport of iodide. And then there are three groups of drugs: thiourea, thiousyl, sulfonamides. You can ignore sulfonamides because it is not obsolete because of its cardiotoxic effects. Thiourea, thiousyl, they block organification. They block iodination of tyrosine. They block formation of mono and diiodotyrosine to act as anti-thyroid substances. And then thiocarbamide and aminobenzene group of drugs. So this neomercazole, which is widely used, like this belongs to aminobenzene group of drug. So this is aminobenzene, this is least toxic, and this is easily available, and it is cost effective, so that is why it is preferred. Thiocarbamide and aminobenzene act as anti-thyroid drugs because they act at two site of action. They block iodination of tyrosine and they block coupling reaction at two sites. And then this neomercazole, the aminobenzene group of drugs, has got least toxic effect, and then it has cost effective and acts at more than one site. It is preferred over other drugs. Now, tomorrow, what we are going to do, tomorrow we will talk about parathyroid gland, endocrine pancreas, adrenal medulla, and adrenal cortex. If the time does not allow, we may carry it sometime else. But in a hurried, pressure-cooked lecture, I know, I apologize, my speed was too fast, but I had to be, because with this few lecture, it was very difficult for me to encompass so much of basic, applied, and clinical aspect of each of the cells, or tissue, or organ, or system of the endocrine gland. So we have got 3-4 minutes. If there's any question, please unmute and you may ask. Thank you very much. Thank you very much for the patience. My advice would be tomorrow, parathyroid and endocrine pancreas and adrenal medulla, especially these three glands, you study as beforehand, then you will enjoy the process of learning. Thank you very much. Any question, please? Please unmute. Please unmute.
Sir, what is the difference between Cushing's disease and Cushing's syndrome?
Cushing's syndrome is tumor of the adrenocortical cells. Cushing disease is tumor of the anterior pituitary cells. But features in both the conditions will be the same. In Cushing disease, ACTH will be more, which will lead to rise of cortisol. In Cushing syndrome, cortisol will be raised because of the tumor of the adrenocortical cell, which will decrease ACTH due to negative feedback system. Yes, please. Any other question? Yes, please, unmute. Yes.
Sir, what was the role of glucose tolerance test in growth hormone deficiency detection?
देखिए चलो मैं medium of instruction is English. For understanding sake, I will talk in Urdu. देखिए हमने देखा कि hyperglycemia leads to fall in glucose. ठीक? हमने 100 gram ingestion of glucose दिया. ठीक, उसके बाद उसके बाद हमने ग्रोथ हार्मोन किया. इन नॉर्मल केस जैसे हम हैं, इन नॉर्मल केसेस growth hormone should be lower level of the normal range. But if stays elevated, that not confirms, but that indicates that there is hyperactivity of the pituitary gland. So the principle is hypoglycemia stimulates and hyperglycemia inhibits secretion of growth hormone. Yes, please. Any other question, please?
सर आपने बताया कि ग्रोथ हार्मोन जो है मतलब फास्टिंग स्टेट्स में बढ़ जाता है ना, या हाइपोग्लाइसीमिया के अंदर मतलब a process known as gluconeogenesis. Sir, but on the other hand, we know that growth hormone is मतलब anabolic hormone है, वो तो मतलब प्रोटीन सिंथेसिस करवाता है ना.
देखिए मैं आपकी एंडोक्राइन hyperglycemic, lipolytic, ketogenic, and protein anabolic hormone. Anabolism जो कर रहा है वो सिर्फ प्रोटीन के लिए कर रहा है. For lipid, it is a protein catabolic. For carbohydrate, it is a protein catabolic. ठीक?
Thank you so much, sir.
You are welcome. Any other question, please?
Sir, which is the most potent stimulator of growth hormone? Either exercise, NREM sleep, or hypoglycemia?
क्या जी?
Most potent stimulator of growth hormone.
अच्छा, दूसरी एक बात याद रखिए, ग्रोथ हार्मोन का स्लीप में ड्यूरिंग द ग्रोइंग एज ओनली up till onset of puberty. After puberty, the sleep pattern of growth hormone is lost. ठीक, एक तो बात ये याद रखें, लिमिटेड. अब आ जाए एक्सरसाइज पे. आपका ग्रोथ हार्मोन क्वेश्चन था और क्या था? एक्सरसाइज एंड
Hypoglycemia.
Hypoglycemia will be a more potent stimulus than exercise or sleep.
Thank you so much.
You're welcome. Yes, please. Any other question? फायदा उठाएं, 2-4 मिनट है. Aslan साहब, are you on the line?
जी सर, सब ऑनलाइन है.
अच्छा अरसलान साहब, अगर क्वेश्चन नहीं है तो कल अगेन 9 to 11 मैंने चैप्टर्स इनको बता दिए और इनका पासकोड और आईडी यही रहेगा. अरसलान साहब, कैन यू हियर मी?
जी सर.
आईडी और पासकोड यही रहेगा
सर आईडी पासवर्ड सेम यही है सबके लिए, हमेशा मतलब पूरा कोर्स के यही है. जी सर, एक पासवर्ड है.
Right. So tomorrow at 8:45, I will open my laptop and will be online on the same topic. और इसी पैराथायरॉइड ग्लैंड से शुरू कर देंगे
इंशाल्लाह. ठीक है सर.
Sir, Assalamu alaikum.
वालेकुम अस्सलाम.
Sir, I have a question. Sir, if we come up a question related to the lecture today, and can we ask tomorrow? Like,
yes. Sure. I loved your question. Yes. अब भूल गया था. Tomorrow, first 10 minutes will be question and answer session from the topics which we have been covered today. ताकि जब शाम को आप पढ़ेंगे, हो सकता है many of the questions or confusion may arise in your mind. So be on time. So first 10 minutes will be question and answer session from the contents which we have discussed today. Yes, please.
सर आप मतलब कोई रेफरेंस बुक आप बताएंगे कोई, मतलब जिससे हम जाके और ज्यादा गो थ्रू कर लें?
देखिए बेटा, रेफरेंस बुक्स तो बहुत हैं, but can you afford time to prepare for FCPS Part 1 from those big huge reference books? यही जो contents जो मैंने बताए हैं आपको, endocrines, physiology और biochemistry से Part 1 की डोमेन में almost 80 to 90% questions in one form or the other इसी में से आते हैं. But nevertheless, Guyton and Ganong's, they are very good books. और जितना लेकिन बड़ी elaborate books है वो, उन्हीं में से guidelines ले लीजिए. They are very standard books. Guyton and Ganong. Guyton and Ganong. Especially endocrine का portion in Ganong is much better because this Ganong, I met him in Sheffield long ago, 15 years ago, or he himself is a neuroendocrinologist.
Thank you, Dr. Aslam. It's end of the session.
Thank you very much. God bless you all.
It was liked by the participants. I could see the messages, and I forwarded to Dr. Shahid to read it.
Oh, thank you very much. I feel inflated.
Mashallah. Mashallah. God bless you.
God bless you all.
Thank you.
Thank you so much, sir.
We'll see you tomorrow.